Our last speaker, Dr. Meenakshi Swaminathan, who completed her residency and fellowship in US and has been a major strength to SN in pediatric ophthalmology. She has had a huge contribution to the academic practice and growth of Shankar Nethralaya in the last 19 years with the devotion and respect of scores of students and fellows with a great passion for teaching, which has ever been in evidence. She would be talking on never to forget the diagnosis and management of Duane and Brown syndrome. On to you, Dr. Meenakshi.
And apart from that, I would just like to add, madam, that ophthalmology aside, she is a voracious reader and has an exemplary culinary skills. I think she has to be accredited for that as well. Yes.
Master Chef for ARC. Master Chef program.
I'm under the impression that Srinivas has left. So I introduce. I'm so sorry.
It's okay. She's well known. No, she doesn't need any introduction. But I think, as Rohit sir said, we'll have a Master Chef program also under ARC, madam.
Yes. But where is she, Dr. Meenakshi?
I'm here. I'm here. Yeah. I put on all this makeup and then my camera was not working, so I had to restart my computer. So that's sorry for the few minutes delay, and without much delay, I'm going to just load my PowerPoint right here. And so I checked with my PGs to just see if they're all still there or have they all run off for dinner.
By the way, the numbers have been very good. There has been very good attendance for a very focused specialty.
Okay, fantastic. Thank you. And thank you, Srinivas, and thank you, Chitra, and thanks everybody in the ARC. So I'm going to share this right here. All right. I think you will be able to see my screen. I'll go into slideshow.
Yes, ma'am.
Is it visible?
Yes.
All right. So DRS and Brown syndrome, are they important for the exams? You bet. So for the theory exam, you may be asked etiology, clinical features, and management of DRS. You could get a long question on CCDD, pathophysiology, clinical manifestations, and management of Brown syndrome could be a theory questions. What are strabismus syndromes? And write a few words about each, maybe a question. Practical exam, you could be shown an ocular motility examination, 9-gaze pictures of either the DRS or Browns or just anything. So get used to reading 9-gaze photos. And you may be shown surgical photos as surgical clips, like you saw in Dr. Meenakshi's presentation, or it may very well be a still photograph in the OSCE. So yes, both DRS and Browns are important. Now, just to make it interesting, mine being the last talk. Now, these are the keys to my talk. So if you see this symbol of the open book, means, hey, pay attention, it's for the exam. If you see the light bulb, it really is to help you understand the fundas. And if you see the brain with the glasses on, it's a trivia or a fun question. And then when you see the gold medal, it means if you're doing well in the exam and you get asked that, it means you're a candidate for gold medal, which means you're doing really well, okay? So watch out for these keys. Aha, right away we have a gold medal. So the question you may be asked is, Down syndrome and DRS and Brown syndrome. What classification are they under in the last decade? How have they been classified? And as most of you should be knowing, they come under CCDD, congenital cranial disinervation disorder, because for these and a whole host of other syndromes, the problem has been localized to the cranial nerve nucleus in each one of these. So let's talk about the clinical features, okay? So Duane's retraction syndrome, what are the clinical features? Complete or partial absence of abduction, retraction of globe on adduction, narrowing of the palpebral fissure on adduction, partial deficiency of adduction, oblique movements with attempted adduction, and upshoot or downshoot of the globe with attempted adduction, and reduced convergence. All right. So here's a trivia, fun trivia. So even though Duane's took all the credit, it's really Stilling-Turk-Duane syndrome. And there's Dr. Stilling from Germany. I couldn't find a photograph of Sigmund Turk, and he's from Switzerland, and Alexander Duane from the USA. So you have to write about what anomalies are known in DRS. The sixth nerve innervation to the lateral rectus is defective. This is the most important point. If you remember anything, this is the most important point. And instead of the sixth nerve innervation, anomalous innervation by the oculomotor nerve happens. And of course, people have guessed rightly that there is absent or hypoplastic abducens nucleus. There were also theories of infranuclear, where cavernous sinus, where the third and the sixth nerve are closer anatomically, maybe something is messed up there. And there also has been evidence of presence of synkinesis along with DRS. As we know, the DRS can be present with Marcus gun jaw winking and crocodile tears. But this was the most important landmark publication in American Journal of Ophthalmology in '98, where they found absence of the abducens nerve verified by MRI. So you need to write this in the exam. This is a lovely little paper where from Dr. Sharma, Pradeep Sharma sir, and Dr. Rohit Saxena, clinical correlation of imaging findings in congenital cranial disinnervation disorders involving abducens nerve. You can see a nice photograph of an upshoot, and they did show hypoplastic sixth nerves in these patients. The gold medal question again. So you may be asked, hey, you know, what really is the genetics of DRS? And it has been shown that the autosomal dominant variant is been localized to CHN1 gene mutations. The others are not as important. Associate ocular anomalies. You need to write at least a few, like common ones like dermoids, crocodile tears, colobomas. And non-ocular anomalies, you're going to see quickly some examples just to get the picture to you. Deafness, preauricular tags, facial asymmetry, vertebral anomalies, foot, cardiac anomalies, spina bifida, etc. Okay, now remember, these are just for your knowledge, just to make it stick there. So no need to pay too much attention, but just put it away right there. Duane radial ray syndrome, or the Okihira's syndrome, and look at how abnormal is the angulation of the wrist and of the thumb. So next is the Goldenhar syndrome. If you remember the preauricular skin tags and the epibulbar dermoid, that's more than enough. Klippel Feil anomaly, there is fusion of at least two vertebrae of the neck, and so they have a short neck. And you have the HOLT ORAM syndrome, where skeletal abnormalities of the hands and the upper limbs are the most important. And look at this girl, you can really see she has a Klippel Feil anomaly with a short neck, and also has a few other deafness and limb deformities. She's Wilder-Vanck syndrome. And then you have Arthrogryposis multiplex congenita with multiple vertebral anomalies. And of course, our good old Oculocutaneous albinism, and a fetal alcohol syndrome with its specific facies. And this, this is just a list of syndromes you just put away there. And when you write about systemic associations of DRS, mention as many as you can recall. But this is a gold medal question. Which medication, which was given in the first trimester of pregnancy for hyperemesis, was later on found to cause phocomelia, or stunted limbs, and Duane's retraction syndrome? The answer is thalidomide. Thalidomide embryopathy. And this was a wonderful work from Dr. Marilyn Miller, who's close to many of us in the pediatric ophthalmology community. This is important for exam. Huber's classification, type 1, 2, and 3. 1 marked or complete limitation of abduction, 2 is adduction limitation, 3 is both. Clinical classification, really we call it isoduanes, exoduanes, and orthoduanes. So in DRS classification, Huber type 1, if you remember that there's marked limitation of abduction, and attempted adduction causes some retraction of globe and narrowing of the lid fissure, that is really good. And this is a picture that's going to, really make that go into that cerebral cortex. So you can see that this is a isoduanes. Abduction is markedly limited. There is some narrowing of the palpebral fissure. DRS classification, Huber type 2. This is marked limitation of adduction with exotropy of the affected eye, and today we would just call it exoduanes. And as you can see, the patient definitely looks exo, and as the patient is adducting the eye, you can see that there is limitation of adduction and there is also an upshoot. Type 3, where there is limitation or absence of both abduction and adduction. So I'm going to pause you for just a second and go over how you will read a 9-gaze photograph if it's presented in the examination. So you would say in primary gaze, the patient has a right hypertropia. In dextroversion, there is a limitation of abduction, and you can comment about whether it's mild, moderate to severe. And you can say in levoversion, there is a marked upshoot with the disappearance of the cornea. It's difficult to comment about limitation of adduction. That is how you will read. And of course, if you find anything going on in the other gazes, you would also read about dextro elevation, dextro depression, and so on. So differential diagnosis, as you can imagine, which you should write when you're describing clinical features for any disease. There's LR palsy, Mobius syndrome, congenital oculomotor apraxia, where the eyes don't seem to move well, infantile ET, where the eyes can be stuck in esotropic position with poor abduction. How do you manage DRS patients? Always treat amblyopia. They do have significant number of anisometropic amblyopia. Remember, it's not strabismic. Anisometropic amblyopia, especially type 1. You have to manage the refractive correction, manage the anisometropia. And if there is minimal abnormal head posture and patient is maintaining a good stereopsis, don't intervene. Otherwise, we do a stepwise approach. We look at, is there an abnormal head posture? If so, what is driving the abnormal head posture? What is the primary position deviation? Is there upshoot, downshoot, globe retraction that are significant? Can the abduction be improved? So abnormal head posture may be because of incompetence of angles, and maybe because to avoid upshoot, downshoot, to avoid severe globe retractions. And if you test in the abnormal head posture, many patients actually have binocular single vision. Look at that. This is the slide is going to actually again going to emphasize how you approach these patients. Two gentlemen, college student, the one without the glasses with the left face turn. This is a teacher, a school teacher, high school teacher from Bangladesh, also with the left face turn. But look at the very different etiologies. This college student, he cannot abduct the left eye. And so he has taken a face turn to avoid abducting the left eye. Whereas look at this gentleman. When he abducts the right eye, he's got an upshoot. And so he does not want to adduct the right eye. And that is why he's taken this face turn. So very different mechanisms. How are we going to manage these patients? I'm just going to run through because there is not much time. ESO deviation, ESO DRS. So what would you do? You will weaken the medial rectus, either unilateral medial rectus recession of the DRS eye or unilateral large medial rectus recession of the normal or the contralateral eye. If larger angles, bimedial recession, bimedial asymmetric recession, medial rectus recession with a small lateral rectus resection. And you can also do help the lateral rectus by bringing the superior rectus transposition with or without the medial rectus recession. Remember, always do an FDT. Is it already time? I'm sorry, I minimized the window.
1 minute, ma'am.
1 minute more. Okay, we're going to really rush through. Upshoots and downshoots can also occur with exoduanes. And this is a gold medal question again. What is this procedure? This is a Y split. Okay. All right. So we're going to now, and I just want to see that with a Y split, this guy did do well. And look at him. His head is straight. So the college student. Brown syndrome. This is Mr. Harold Whaley Brown who described the syndrome, also known as the superior oblique tendon sheath syndrome. There's the Helveston theory and the Wright's theory. One says it's a developmental anomaly, and another says it's a short, stiff tendon. Clinical features, I'm going to go straight to the picture that will tell you all the clinical features. Chin-up posture, primary position hypotropia, adduction, there is marked limitation of elevation, sometimes a downshoot, sometimes a widening of the palpebral fissure, and classification could be congenital, acquired, so many causes of acquired, particularly inflammation. Look at this little kid. You can see the huge inflammation of the orbit, and there is a cyst, a cysty circus. And on resolution, she still has limitation of elevation, but much improved. As you can see, some limitation of elevation. Classification can be according to the severity. And here's a trivia question. What sport does Dr. Wright excel in? Kenneth Wright, who described a lot of things about Brown syndrome. He's a great surfer. He's won a lot of medals for surfing. So differential diagnosis is IO palsy, MED, CFEOM, orbital flow fracture, thyroid eye disease. Conservative management in most patients that can have spontaneous resolution, anti-inflammatory therapy if there is inflammation, indication for surgery, it's a large AHP. What do? First do an FDT. Make sure the superior oblique tendon is indeed tight. And then you can do a tenotomy, a right silicone expander, or a suture spacer, which we call the chicken suture. This may be a gold medal question. You may be shown this and asked, hey, what is this procedure? It's a right silicone expander for tenotomy or weakening of the superior oblique. Thank you, ARC, and thank you, Dr. Chitra, for organizing these wonderful PG-centric programs. I wish the postgraduates all the very best. Thank you.